Thank you very much. Good afternoon, everyone. We'll keep it very, very free-flowing. And the idea is we have such an esteemed panelist with us. So idea is to learn from their experience, what has worked in telemedicine and remote monitoring, what is exciting them, what are the challenges, and what is the way ahead, right? That's the broader structure, and we can, the way I would want to structure is, I think I'll start with an opening remark. I was part of the founding team of 1MG, been seeing that telemedicine's journey from the time when we were kind of before COVID times, when we were doing the teleconsultation, and during COVID time, the inflection point was obviously the telemedicine guidelines, which were, formalized or given a structure to the entire telemedicine piece. And post, there were times of excitement, there were times when it was not moving that great as a business model, right? So we have gone through those phases of very, very excited about that everything would work in telemedicine and remote monitoring, and then there was a absolute valley that is not working out, and then there was a realization and actualization that within this pocket it works well, this other pockets it doesn't work well. So the entire industry has gone through that phase because of pandemic, at the inflection point being the regulations. So the idea is to learn from the panelists that last 4 years, what has been their key learnings from this telemedicine and remote monitoring. And I would request everyone to introduce themselves, brief background, and maybe an opening remarks on what has been their experience last 4 years with telemedicine and remote monitoring. I'll request Dr. Sanjay, if you can start with your kind of experience, because at scale that has been done by the government, and we would be kind of very eager to hear your comments on that piece.
Thank you so much, Dr. Gupta. And at the outset, I thank the organizers to giving me the opportunity to talk about eSanjeevini along with the esteemed co-panelists. Well, I am heading the Digital Health Innovations Division at CDAC in Mohali. And as a part of the activities here, I'm also directing, or rather I'm the project director for the National Telemedicine Service of Government of India, which is eSanjeevini. And besides this, we are also working towards a number of other digital health innovations, which includes recently we've been entrusted with the responsibility of managing and developing as well the national portal on NCD, which is a
So we'll resume, we'll wait for that, but I would request, let's wait for 30 seconds. I think all of us have heard about eSanjeevini, right? Yes. And the massive scale and the impact eSanjeevini as a service, as a model has been able to provide, I think it's massive. One of the, I would say, successful case studies in this particular piece. While sir is joining, do you want to come in, introduce yourself, and maybe tell about what has been your experience?
Yeah, sure. Thank you. Thank you very much. My name is Manasije Mishra, and I run a digi-physical healthcare company called DocOnline. We have been working in this area for more than 8 years now, and have served more than 7 to 8 million families have been looked after by our doctors. Our model on telemedicine is a little bit different from the market and quite different from many other startups. We believe we are a clinical establishment first. So for us, the quality of healthcare and the quality of consultations that our doctors deliver comes first. And the technology part we see as an enabler. So we don't see ourselves as a digital marketplace or a meeting place for doctors or a doctor discovery platform. So we're a healthcare company. We happen to deliver some of our services through technology, through video, through chat, through audio, and also in the community health model, and we run a very successful community health business. We believe that telemedicine on its own doesn't really serve the underserved and the underprivileged. But if you have assisted telemedicine, where you have a qualified nurse who is physically present during the consultation, but the doctor can be remote. And that's something we have actually built out at scale. And I think it's been tremendously effective in reaching very remote communities at a very, very low cost and providing both GP and specialist care right down to the last mile. And the incredible thing is that we can do it at very high quality, but at a very, very low cost. So it's been a very interesting journey. And I think you're delighted to be here.
What have been your learnings? Which specialties it is working more? What are kind of 4 years, how would you put together your learnings in this space?
So in the community health area, and if you look at the rural, because that's just focusing, because that's one part of our business. Obviously we have a B2B business, which is for corporate employees. We have a distribution business where we sell indirectly primary healthcare packages. But I'm restricting my remarks more to the community health space or to the rural space, because that's the agenda today. So there, I think what we've found is that when we started, and I think the first rural project we had was in 2020, before COVID. So, 2019, 2020 is when we launched our first kind of rural project, which was actually a small pilot project with the UP government. What we found on the ground and what we thought was totally different. Like, we thought that the recipients or the patients will not accept telemedicine. We thought there will be a lot of technology barriers. We thought that there will be a mindset issue that a patient will not come to you because you have a primary healthcare center where there is no doctor. And what we found in reality was totally different. That amongst the rural population who have had no access to good quality primary healthcare, the fact that you have a nurse present, the fact that the doctor is available on the computer screen, on the laptop screen, the fact that there is assistance in terms of the medicines being available in the primary healthcare centers, we ended up attracting not just the catchment area that we were supposed to serve, but even people from 20 miles, 25 miles, 30 miles radius were flocking to our primary healthcare centers, avoiding many of the primary healthcare centers which were actually closer to their home. So that was quite an interesting learning, that actually the acceptance of telemedicine and the ability to deliver quality it was not an issue at all. And I think I think eSanjeevini is a fantastic project and the government has done an amazing job. But I think I would say that I wish we were building this at scale, and only the government. Frankly, I think the whole idea that a doctor and patient should meet in person in primary healthcare is really obsolete. And I think in the next 20 years, people will find it bizarre that you ever met a doctor in person. I mean, to me, it's a strange concept. Why should a doctor and patient be together in the same room? It creates all kinds of problems and doesn't really solve for anything. So, that's what we've learned, that you can actually deliver 80-85% of primary healthcare remotely, more successfully, at a higher quality, with a lot of monitoring, with a lot of emphasis on making sure the doctors are following protocols, the doctors are disciplined, the doctors are actually driven with the client's best interest at heart, which is impossible in a physical doctor-patient relationship. So,
yeah, very valid point. I think China has moved to that model, right? So because a lot of the primary healthcare challenges or the symptoms or the signs and symptoms, they don't need a physical visit to a doctor, right? So sometimes this is like indigestion, headache, all those things. A triage can be done by a doctor online and say that which requires a physical consultation, which do not require a physical consultation, and that solves for the infrastructure challenges, indirect cost challenges. I think very well said that there is a clear opportunity from a patient effectiveness versus the infrastructure we have is to move the first level of primary healthcare digitally, right? And I think the entire China model is they have moved to the primary healthcare to the online and remote monitoring. I think that's very good point, very valid point. We'll just check Dr. Sood if you're back online. Yeah. So, sir, over to you for your introduction and what has been your learnings for the last 4 years in this space.
Thank you very much. I am Sameer Kanwar. I am the Director for Digital Health within international not-for-profit organization called as PATH. We work across the public health space with governments across countries. We work in almost 75 plus countries, largely supporting public health with the governments very closely. And before we actually get into what's been the learning in the past 4 years, I think what we need to understand in India's context is the need for telemedicine, right? I'll just throw a few numbers because that sets the context as to why it is important and why actually probably we are one of the countries which has actually picked it up and sustained it beyond COVID. A lot of other countries have probably dropped it because of other reasons, right? So if you look at the WHO doctor to patient ratio, which is prescribed as 1:1,000, we have it at 1:500. 1:1,500, right? So we have a lack of doctors. Our public health facilities, as well as private health facilities, are urban focused. 70% in urban. The population is only 30%. The requirement is in the rural. So there's a gap between the availability of healthcare providers as well as facilities, right? On the other hand, if you look at the tech stack of India, probably we are one of the best in the world. We have the cheapest internet. We have a penetration of 95% plus of internet in villages. Almost like 650,000 villages in India have internet. 1 billion internet users in the country, right? Out of this, 45% are rural, right? 85% of Indian families have a smartphone, at least one smartphone, a household, right? So you have all the technical stack in terms of infra which is available, and here you have a gap in the healthcare service delivery, and also as far as health service delivery goes, we have the maximum out-of-pocket expenditure in the world, almost. We top that, right? So there are all the reasons why we should be looking at telemedicine being adopted, right? And I fully agree with what Mr. Mishra was saying in terms of it has to be assistive. And he talked about, an ecosystem approach. You have to have the medicine, you have to have the nurse, you have to have the doctor, you have to have a very stable internet connectivity, and then only this is going to work. If you don't look at the ecosystem, it's going to fail us, right? And there have been use cases where we've actually failed, right? Because of these reasons, right? And we have been extremely successful in other places where we've had this ecosystem kind of an approach. Now, there was also a study which was done for eSanjeevini, I think it was Uttarakhand or Chhattisgarh, which talked about a saving of almost about 940 rupees per consultation and a saving of a distance of 23 kilometers of travel with each teleconsultation. Wow. Now, that's the kind of impact which we are looking at, right? But then, like he said, if we don't do it in an integrated manner, it's going to fail us, right? So the learning for us has been, in terms of last 4 years, and I would talk more about post-COVID than during COVID, because COVID, I mean, we had a emergency and we were forced to use it, right? And by the way, in COVID, 85% of doctors use teleconsultation. And a study says, there was some kind of an evidence building which was done by an organization, and 65% of them said they would continue using it post-COVID, right? I am not too sure how many are actually using it post-COVID, but that was the statistics given. All right. Now, I think one of the biggest levers which we had with the government was the policy lever, right? Probably India was the first country to come out with a guideline which said that I could prescribe a prescription of a basic EDL, which is your basic drug list, which could be prescribed by a doctor through a teleconsultation, right? So those are enablers and levers which need to be active, right? The experience has been that it has gone phenomenally in terms of in the private sector as well as in the public space with different use cases now, right? So he talked about a hub and spoke model. Now there's a direct consultation model also basically for screening what you were mentioning, right? In terms of doing the triage basically, which can actually be done by a nurse, right? The third level is you have something known as a tele-ICU in place today, right? And very effectively being used in public health space also. There are doctors from AIMS who are giving consultations, AIMS Nagpur, in Maharashtra through a teleconsult. So you get the entire data up onto the platform, and he's able to monitor it and give advice to the doctor who's sitting there to take it forward from there. So there are n number of use cases. You have point of care devices available, which are tracking continuously. So it makes all the more sense now to use telemedicine. The only place probably I'll differ with him is, in terms of the human touch. So if you go back to your family physicians, they are extremely uncomfortable with using technology. And there's a reason to it because, healthcare is often very, very subjective, right? There is a family context. He knows your family. He knows your father had probably a BP and therefore you would also have a BP. So there's a lot of family and genetic connects to it, which also need to be accounted for, when you look at that human touch being missing as part of the technology. I'll just park it here and probably we can take the discussion forward. Thanks.
Yeah, I think very, very valid point. I think you mentioned about tele-ICU. It's a very, very big use case, right? It's a very successful use case. We don't have critical care specialists all across, and ICUs now is a big use case. Second, I think the important point you mentioned about integrated care ecosystem, I had this experience of working with common service centers, just adding to that piece. Common service center being 160,000 common service centers becomes an infrastructure point for consumers to come to that place. There is an internet and computer in place, and there is a person in place, and that person can act as a facilitator and can help adopt the technology for the user, right? So he or she would log into the system. And so we had so many cases where we delivered those medicines in the absolute rural area of UP, and when we send our team and said कि ये कौन order कर रहा है, जाके एक बार देख के तो आओ कौन है, मतलब who is that particular person, we realized that एक particular village था जहाँ पे it was at a point where every city was very, very far away from their place, and the entrepreneur or the VLE who was managing this CSC was very enthusiastic of conducting the camps, promoting the service, saying that come, this is a place where you can talk to Apollo doctors, you can talk to these doctors, and you can get your medicines and diagnostics also delivered at home, certain kind of diagnostic. And it was successfully done in that particular micro geography. Over to you. I think your experience is different from the community here, but you can.
Sure. Before we start, just a small correction. I'm an engineer and MBA by background. I'm not a doctor. So whatever opinion I share is from a non-clinical perspective, right? Dr. Varun, when you said, if we look at a journey from last 4 years, what demonetization did to digital payments, right? It created an accelerated awareness and adoption for digital payments across India, right? And it grew on a steady state. But when we talk about COVID actually created a lot of awareness, but the adoption rate has been less for telemedicine, if I say. And doctors or patients, when they started going for telemedicine during that time, they've again gone back, most of them have gone back to being more comfortable in physical format. And this is primarily for the urban sector that I'm talking about. Now, our challenge is from the rural sector. The major challenge is, first of all, from awareness. As Samir mentioned that internet is 95% of the villages are already internetized or have internet, right? But is there an awareness or a comfort factor of people of villagers that they are okay with having a teleconsultation, and they actually, I'm not sure whether how much they have faith in that, right? Because what they give more weightage is to have a physical conversation with a person. Even if it's going through a video call, I mean, that awareness and faith has to be developed over time. And once we do that, then is when adoption comes in. In the last 4 years, we have also seen AI and ML going to a different level altogether, with ChatGPT and OpenAI launching in 2023, right? And telemedicine and remote patient monitoring systems and softwares have actually taken a tremendous leap in the last 1 year. Because now we have a lot of data sets which these models can learn, and we'll discuss more during our conversation. But my belief is that these two factors, where awareness in rural sector and AI and ML, that needs to be merged together to create a better solution for a rural sector.
And in your particular domain, do you find that we will be interested to know in your use case, even if it is an urban private, how does this remote monitoring or the patient or telemedicine works?
Sure. So let me give you a background. I work with a company called Align Technology, which is a medical device company and the makers of Invisalign, right? Now, the treatment, which is a counterpart to metallic braces, it's a plastic tray. If you know Tootsie and all, right? It's a kind of a plastic tray which you use to fix the gaps and irregularities of your teeth. The treatment cycle ranges from 6 months to 2 years, right? And in braces, what happens is a patient needs to come to the doctor every month to get the metallic braces screwed and tightened together. But this specific device is something where you can do the whole treatment at the comfort of your house. You just get the package delivered at your home. But the thing is that the doctor needs to monitor everything throughout your journey, right? And this is where remote patient monitoring comes in, where we have softwares developed which click the photographs of you wearing the aligners, and it actually tracks whether the teeth movement has been done correctly or not. And if not, the system tells the doctor and the patient both that they need to meet at this time or within these couple of days, so that the corrective actions can be taken, right? So we have actually deployed algorithms in AI and ML to track the patient journey. Patient can click the photographs every week and send it to doctors, and then the doctor can do remote monitoring. The notification only triggers to doctors if there is anything faulty. If things are going good, doctor sees a green check and then he moves to the next patient. So this is how the...
So tell me one thing, getting into the depth of what you said, I think it's a very perfect use case, which is not an acute, not a chronic, acute chronic, I would say. 6 to 12 months is a good sweet spot of acute chronic, where the first visit could be a physical visit.
Right.
Is that the case? First
Yes.
visit is the physical
Yes.
visit, where the doctor examines and say that the patient would require a particular brace,
Right.
prescribes the brace, and then every month the brace gets delivered at home, and the monitoring is being done through images.
Right.
And do you also have a command center where the GPs, or in this case the dentist, would monitor, and maybe an orthodontist would be remotely available? Is that the system? You have built a hierarchy of specialists depending on the challenge people would
Since
face.
our major business is B2B, right?
Okay.
So we do have a command center, which is kind of a software operated one. We have built everything in the system, and as soon as the person clicks, and now we have data of around 27 million patients from last 26 years, right? So assume this kind of a huge data. You can actually track every of the movement of teeth, and you can track whether it is going according to the treatment defined by you or not, right? Because it happens in stages. Each aligner you wear for a couple of days, 10 days primarily, and then you change to the next aligner, and each aligner gives a different movement to a different teeth. So that's the reason why patient monitoring becomes critical. The first, obviously, is a physical interaction where the doctor scans the teeth. It creates a 3D model in the software, and then creates a treatment plan. And then the tracking happens remotely.
So it's a very perfect way to say that it's a hybrid model, right? So that's where it's a hybrid model: physical consultation followed by remote monitoring, continuity of care managed through technology, and then use of 3D and AI ML to kind of create the entire structure. I think this is what is emerging from the discussion, right? So as you rightly said, tele-ICU is one, again, a good sweet spot. This is a second sweet spot. Third sweet spot I've seen is the tele-onco consultation. Tata Memorial runs a very successful tele-consultation model where a cancer patient from all over the place can take a second opinion from Tata Memorial Cancer, and they can send out the whole set of reports and everything. You don't need to travel to Mumbai to get that opinion. A set of panel of doctors sit and they give you a very detailed report, right? So again, a specialist, accessing the specialist from wherever you want to, right? But there have been a lot of, I've seen both sides. There are a lot of failures I've seen in telemedicine, right? So a lot of entrepreneurs started their own ventures, closed down. I know of a gentleman who started this. He patented one device which can be taken to a doctor's cabin, and that device has all the kind of monitoring tools, and the data can be transferred from this doctor's cabin to the patient. This device was an interface for the doctor, and there was a similar device at the patient's end, and this device was acting as to transfer the data. But again, capex heavy, utilization is not that great. And the largest problem, which I'm talking from a commercial perspective, is that for any business model to work in a private setting, either the LTV should be high, lifetime value of the patient or the customer acquisition should be high, or the AOV should be high, average order values should be high. In a primary healthcare setting, unless and until it's not funded by the government, the AOV is very, very low. And the customer acquisition versus the LTV value does not sustain itself. And the pockets in which it works, like we said, ICU, cancer, all these are high AOV kind of categories.
So there are huge margins in that.
Huge margins. That's what's sustaining. And I would want to kind of hear from your what has not worked, let's say there is an opportunity out there, but as we say that always the learnings do help to find pockets of saying that these are then the learnings, let's see where we can build, double down, triple down on that piece. So I'll open the floor to you, say that what has not worked for you? And for this audience, candid learnings would be very, very helpful, and say, okay, this has not worked, this has been my learning, so that people can think and build from those learnings. Yeah.
I think there are two parts to your question.
Yeah.
One is you said why many of your friends, since you come from that very entrepreneurial kind of background yourself, and why many of the startups have failed. That's one question, which is, maybe I'll give a very brief answer to that one, because but the other question is, what can we do to take healthcare in rural India to communities at a very low cost? So I think fundamentally, one thing is true, whether it's in rural India, whether it's for rich or for poor, urban, doesn't matter. That is that I believe fundamentally that healthcare is a business of trust. It's not about solving for access. It's not about solving for cost. It's about solving for trust. And in the urban kind of startups that we have seen, many have disappeared. And in fact, amongst the investor community, telemedicine today is a bad word. And the reason is that most of these people had a marketplace model where they believed that they were solving the technology challenge of connecting the patient with the doctor. And they got a panel of thousands, in some cases lakhs of doctors. And the customer went there. It was a marketplace. So like a classic marketplace, there was discovery of price, price discovery of the doctor, payment was made, the platform charged a commission, and it never worked. Why did it not work? It's because the cost of acquiring that one customer was extremely high and there was no repeat. Why was there no repeat? Because no trust was built. So on the urban setting, the way we are solving that problem is making sure that any doctor who speaks to my patient is an employee of DocOnline. So we don't have this kind of panel of doctors. We don't have doctors traveling, in traffic and doing a couple of teleconsultations on the phone while they're in the traffic. We don't have a concept where the doctor is sitting, room full of patients waiting, telemedicine call comes, he also does one quick telemedicine call. Frankly, it's a non-serious application. So, but that's the urban story. On the rural side, I think one of the things that you will hear from the rural consumer, or a poor, or even in an urban setting, there's enough urban poor. And recently we started working in urban slums in a number of cities. I don't know how it's happened, but suddenly we've got projects in Mumbai, in Noida, in Hyderabad, and Bangalore. So suddenly we, for the first time, for the last 6 months, we had never worked in urban India, in a community health setting. Now we've got these projects. The villager says, I am going to get medicines. मैं दवाई लेने जा रहा हूँ. And I think,
Very good statement.
Mr. Samir, you were saying that it's a question of integrated. And this is part of that mindset of the patient. If you ask the patient, if you went to see a doctor, what was the value of the consultation, they will find it very difficult to say that I will pay 100 rupees or 200 rupees or 300 rupees for that consultation. That concept is not that strong in their mind. They are sick, they have a problem, they want treatment. वो दवाई लेने जा रहा है, treatment लेने जा रहा है. वो, he's not interested in the gyan the doctor will give. So what we have found is that in our most successful models, like we have run this at, not as like government scale, but as a private sector company, we've done about 2,000 villages where we had a nurse on a scooter. So we called it our clinics on two wheels model, where our nurse would travel to 2 villages a day to keep the cost down, and she would hold 3-hour OPD clinics in each village. But this nurse was going, as I think Mr. Kanwar pointed out very, very nicely, in an integrated way, because she had a lot of point-of-care diagnostics, which is now quite cheap, easily available. We're not talking about high technology, AI and machine learning. We're talking about simple devices, blood pressure. We're talking about temperature, with oxygenation. We're talking about random blood sugar. We're talking about a thyroid test. All can be delivered using strips, drops of blood, and just devices to check. And a nurse is fully qualified, fully trained to be able to use those devices. So that's the one first. So point of care diagnostics. So before the consultation starts, the nurse is able to do a thorough physical examination, including the blood pressure, the height, weight, the BMI, the fat content, etc. Have a conversation in the local language. That's also important because the doctor can speak Marathi, the doctor can speak Hindi, but the accent and the nuance in rural India sometimes is a challenge, right? So the nurse can solve that problem. Second, she does a basic triage, and in most of our projects, we've had GPs, pediatricians, and gynaes. You were asking which specialists. Yeah. So in a rural setting, it's the women who are the most underserved. So therefore, and the children. So we have found that if you have a package of GP, gynae, pediatrician, you're taking care of a lot of the community. And our programs have attracted 70-75% of the beneficiaries have been ladies.
Okay, very interesting.
The nurse does the consultation, the doctor can have a discussion. Doctor can tell the nurse, Acha, sister, do you mind just doing a random blood sugar? Because from the symptoms, I'm hearing diabetes. You're there, quick random blood sugar, and you're done. Can you check the blood pressure? Because I think there could be a blood pressure problem, right? Can you ask the patient to stand up and move her leg or move her arm in a certain way, right? So there could be some orthopedic or some musculoskeleton related diagnosis, right? And then the nurse is also carrying drugs. Of course, she's carrying simple drugs, basic drugs, which are there for primary health care, and she dispenses them. Now, this kind of program we've been running, you would be surprised, on a per village, per month basis for around 5,000 rupees. So if you want to deliver quality health care to a remote village through this model, it's about 5,000, maybe 6,000 rupees, depending on the geography. It's, how much driving distance and all that sometimes makes a difference. Scale makes a difference. So where we have run it at scale, for as little as 5,000 rupees, you are able to take care of the primary healthcare needs of a small hamlet. Typically, the population will be 500 families, 1,000 families. Now, most of the villages in India are quite small. Yeah. They're not like lakhs of people, right? So I think that when you go in an integrated way, when you go and put quality medicine, our doctors are, even these doctors are monitored. So their consultations are being recorded by us. And our clinical directors here, he and his team monitor those. Sure. To make sure that the doctor is polite, to make sure the doctor is behaving perfectly well. Doesn't matter if there's a poor patient.
There's an audit of the entire. There's an audit of the entire consultation.
And our whole objective is that it doesn't matter whether you're rich or poor. The doctor must behave in the same way to you. Yeah. The doctor must listen to your symptoms carefully. The doctor must prescribe accurately, give you the correct advice, right? Never happens. I have not heard of any healthcare system anywhere in the world where a doctor is being constantly audited. But I'm a banker, ex-banker. How can you run a process without audit? Yeah. So to me, healthcare is very strange. I'm not a doctor. To me, healthcare is very, very strange. Most of healthcare runs without audit, without a second opinion, without a check and balance, right? Yeah. Yeah. So I think when you solve for trust, whether you're rich or poor, you will have a successful business model.
I think the crux is building that doctor-patient relationship, building that trust, and that trust would solve for a lot of other things, right? So repeat and everything. And do you think in an urban setting, rural setting you said about this, but an urban setting, is there an opportunity to create digital first or a virtual hospital to say simplistic is that cloud kitchen is a concept, right? Can't we have a cloud hospital that there is a hospital fully staffed, they are on the rolls, but all of them are available digital first. Your first consultation happens in a digital manner, and you don't need a lot of OPD spaces. The hospitals have been designed in a certain way that increases the entire cost. Can we have a virtual first or digital first or a cloud hospital concept in future coming in for the country? Is there an opportunity out there?
So I wouldn't use the word hospital because hospital talks about secondary care, tertiary care, which is a complicated area, and I'm not qualified to speak on it, right? I think in the primary healthcare space, like we have it is a virtual clinic. It just, like I said, the doctor and patient have to be together in time, but not in space. And I fundamentally believe that it is a really bad idea if you want to put doctors in front of patients, particularly in rural India. A doctor who has studied so hard, who has done a good qualification, will never want to take his family and live in rural India. Life is tough enough in urban India. So why would you even imagine that I can hire a doctor and put him in a village? I mean, it boggles my mind. that we would even imagine such a model, right?
Sure.
So to me, there is only one way of doing primary healthcare. So I think what you said, I must respond to that. And I think you are absolutely right in saying that the old family physician had tremendous value. And if anybody here has an old family physician, hang on to him or her, because you have the most valuable thing in the world. Unfortunately, I believe that the economic model of that family physician has disappeared, because the real estate costs in India are so high that for an MBBS doctor to set up a family practice in a Mumbai, Delhi, even in a Moradabad, or I think the kind of rental he has to pay and the kind of per consultation fee he will get, he will never survive.
Sure.
So that's why they've all disappeared. You will only find them in black and white films. But there are a few families. Sometimes when I say this, somebody stands up and says, no, I have a fantastic family doctor. So therefore now I start by saying, if you have a family doctor, that is the best model.
Sure. In interest of time, sir, we want to hear your views on what has not worked, what has kind of learning from the failures.
So I think the challenge in healthcare is the requirement is in the public health space, right? And the technology or the innovation happens in the private space, right? It's a huge investment. Like if today I am an innovator in the healthcare space, it's going to take me about 3 to 4 years to probably get my technology certified. That kind of an investment coming in itself. I mean, I'm not even talking about, going beyond a pilot, right? You need to build evidence, you need to do a lot of research, you need to get research organizations on board, academic organizations on board. And at the end of the day, you have a product which can actually scale. Unfortunately, the scale is in public and the government is unable to procure that technology because it's not about the money. The money is available, but the procurement processes are so complex and the policy framework around it does not. I may have the best technology and I can give you hundreds of examples of primary healthcare technologies which we piloted, and we call the healthcare sector as the graveyard of pilots because we've done, I think I myself have done about 50 of those pilots, right? And we are doing them right now as well, where we know, unfortunately, that it's got huge impact. But unfortunately, at the end of the day, the government cannot go out and say, oh, I want X, right? I want to procure from Anurag. He's got the best technology, so he's going to support us in let's say a lack of villages. It can't happen that way because the government procurements don't work, unfortunately, like that, right? So I think that's where the link fails in terms of technology. I think another point which we need to understand also is healthcare is not a priority in our country, right? We go to a doctor only in an emergency, right? I would not go to a dentist to get my routine checkup. Absolutely not. Even I don't go. Unless and until my tooth bloody aches and I don't sleep in the night, right? So that's a fact we need to realize. The government also doesn't make it a priority. You look at the GDP budgets, right? America spends 14%, we spend 3%. Whereas health actually is important, more important for us than probably for them, right? So unfortunately, I think because the priority is not there, so therefore the business focuses are also different. Lastly, I think when you look at look at, don't call it telemedicine, teleconsultation, look at it as only as a means, right, to deliver. So we did a kind of a taxonomy across the world in terms of, these different, teles which we use, right? So we came up with, I think, a dictionary of about 5,000 of them in terms of telemedicine, teleconsultation, tele-ophthalmology, and you name it, it is there, right? So I think we need to just break it into two and say, okay, this is my means of delivery, right? This is one method I can deliver healthcare service, and let's use it like that, rather than, trying to stitch, healthcare very specifically to it. Right? Thank you.
Yeah. Anurag, what has been your experience? What has not worked? I mean, I wanted to, for the audience, failures are also very important data points.
I'll talk about rural. I'll talk about this other aspect later. I believe entrepreneurs need to look at it from the fact that the fortune lies at the bottom of the pyramid and devise and create systems which are at scale for the rural, right? What most people focus on is to create more margins in their products and services, and then with higher margins and higher value, your TAM and total acquired market and your customer segment shrinks, right? So we need to build with the focus that you can create more value if you have more customers, right? The second aspect is awareness again. In most of the villages, people go to their chemist for medicine. They don't even consult doctors, right? Combiflam is the go-to medicine.
Yep.
And trust me, I have seen people recommending Combiflam to their expecting wives, even though Combiflam is not a apt medicine during that time, right? So awareness needs to be created that probably chemist is not the right person to give you a medicine. You need telemedicine. You need to consult to a doctor, a certified doctor. And again, now coming to Invisalign, the major hurdles have been obviously the price point, because we are focused on the niche. It's a private limited company, right? It's a listed company. All the focus would be on margins. So obviously there will be more margins, and we'll create more value, but again, it's for a niche and for urban. For rural, we need technologies which can scale up and create more awareness. That's my point.
Sure, sure. And I'll just switch, and there are the last 2 points I would want to touch is technology coming into telemedicine, AI, ML, and the data privacy challenges, issues which kind of come across with all this. So I want to touch on these 2 aspects. I remember we kind of had an intern from one of the IITs. He said, we told him that teleconsultation में ये करना है, ये technologies करनी है. वो intern second year, third year था. उसने आके कहा कि मुझे ना सर ये समझ नहीं आ रहा कुछ भी. मुझे तो ये नहीं पता कि मेरे पैर में दर्द है तो मुझे किस डॉक्टर के पास जाना है. पेट में दर्द है तो मुझे गैस्ट्रो के पास जाना है, मुझे जनरल फिजिशियन के पास जाना है, मुझे सर्जन के पास जाना है. I don't know, even understand that how to select a specialist, right? I don't understand this. I come from a particular background. So he said, I will do an experiment. I will get all the data, train the system to help you identify the specialist. You type the symptoms in any form, I will identify the specialist 1, 2, 3, and then the system would learn based on whether the specialist has been allocated right or wrong. Because the problem for us was that people would select a wrong specialist, and then when the specialist would kind of put to a different specialist, the time is wasted in the entire piece. And second person said in the technology piece in this value chain was that doctors do a lot of repetitive work in collecting the patient history, right? So can there be a bot or a whatever technology which can help summarize the entire piece so that the consultation becomes more effective? I could see these 2 use cases very, very effective in terms of where technology was able to kind of facilitate the doctor-patient relationship, make that consultation more effective, right? So that has been my learning on that piece, and I would kind of go in this sequence, and we have you have to take 2-3 minutes to speak because we just have to summarize this piece, and then we can go around closing remarks and data privacy. How do you see that risk coming in with this piece?
So obviously, I think data is important, and privacy of that data is extremely important. But I think on a digital platform, it's an expensive problem to solve, and it's an important problem to solve. But it's not a problem that cannot be solved. I mean, so you can create secure systems, you can create secure repositories. As far as machine learning and AI is concerned, my quick response at this point in time is that we have no ambition to expose our patients to any AI or machine learning. Because I think that stage, I don't know if ever it will come, but it is certainly not in the first stage. In fact, I believe the problem that you articulated, or this young intern articulated, was the right problem. But the answer to that is in a healthcare system, you have to go to a GP first. In India, we don't respect the GP. We believe we are all very clever, and we can decide that we can go to a cardiologist directly or to a dermatologist directly. And that's a big mistake, and that results in a lot of waste of money, time, over-diagnosis. So that's a different sort of issue, and to me, it's a philosophy issue. To me, your GP has to be your first point of contact, and then you get onto a sort of secondary care specialist. That's why it's called a secondary care specialist. But in doctor assistance, and you mentioned summarizing of health records as a use case, that's something we are very excited about. And in fact, we are now going to be running some, we are a small company, but we're going to be using some of our limited resources to try and build that. Because I think that the first application of AI and machine learning should be focused on helping the doctor. And you described a very, very good use case. And there could be similar use cases where the whole focus is, how do I make my doctor's life easier? And not try and solve the sort of holy grail where you think that a patient comes in, he can speak to an AI bot, the AI bot can prescribe and treat the patient. I think that is certainly science fiction today, and maybe 100 years later that's going to happen, because most of what human beings imagine ends up happening. So I'm not ruling it out. But I would say that our focus, and I would request that the industry's focus should really be about not so much in interfacing directly with the customer, but making your internal processes, whether it's a doctor or customer service processes, using AI to make it more efficient, effective.
So I'll give you an example of the work which we are doing in one of the districts in Maharashtra, in Satara. So we are helping the government, to look at how can we effectively use technology to screen population level, screen the population for various diseases, right? And that's where, the applicability of technology comes into public health. And when we look at, let's say, an AI stethoscope, right? When we look at, just picking up X-rays happening in the public health, and how do you solve public health problems, right? Now, one of the recommendations which we are working with the government is that to solve the TB problem, right? We are looking at eradicating TB 2025, right? Now, if you look at the number of X-rays which are being taken in public health facilities, if you just run them through an AI tool, you will be able to scan them for about 30 lung diseases, of which one is TB, right? And now, if you just go back to the evidence, the government of India had done a study about 3 years back, which says that 50% of the cases of TB in India are asymptomatic now. So you do not have symptoms. You are not going to a doctor, but you still have TB and you are carrying it and you are spreading it, right? So now if you basically start using, just you taken a lung X-ray for any reason in a public health facility, just scan it through AI technology in 10 seconds, 20 seconds, you are coming up with those potentially 50% cases which you are actually missing out when you are not capturing the symptoms, right? So I think there's a huge amount of use of technology in healthcare. I think the challenge and the problem which we are facing globally is who is interacting from the industry with the public health sector or with the health sector per se to find those problems. And I'll give you why I'm saying so. If you look at the overall market of AI and ML in healthcare, right? 40% of the investment is coming into diagnostics, right? 10% is coming into cancers, and only 4% is coming into solving the problems he was mentioning right at the back end. How do I ensure in public health that my doctor is at the right place? Is there load there for the doctor to be there? Or should I be putting the doctor somewhere else? Where should I be opening the next public health facilities? Right? All this can be solved through technology, but there's only 4% of investment coming in there. So how do you control this market investment, because you are all from the private sector, right? So unless and until you are very closely interacting with the healthcare ecosystem, right? And like I said, the application is in the public health, and if you don't solve those problems, you are never going to get business out of this, right? At least in a country like India or any other LMICs, because we work across countries, right? So the technology which you are picking up are from high-income countries, right, where there's awareness. We just talked about, that we just pop pills, right, without even any prescription. We are a society like that. It's not a priority for us at any, right? So how do you build businesses is by interacting with the entire ecosystem and then look at solutions rather than just picking up technology from somewhere, getting it in because it has worked there, it will work here. It is not going to happen. And that's why where we are actually failing in the space.
Anurag, your closing
Just the last
remarks.
comment that India has its own nuances, right? I completely agree. We cannot pick up technology from other countries and then try to deploy it in our rural sector. But the thing is that the way AI and ML has translated in the last 2 years, I think there's a huge potential for healthcare across its value chain to adopt these technologies and create more value, both at urban and rural segment. That's my point.
I think very, very good, healthy discussion. I'll just summarize broadly and we'll open. If there are some questions, we can yeah, please.
So my name is Umesh, and I'm building OPD Shore as an entrepreneur. So I have a question. Preventive healthcare and primary healthcare is the least priority in India, especially the young population. So what do you think about the future of the startup who are, coming into the healthcare or primary healthcare. So what do you think, what would be the future for them to in next 5 to 10 years?
I mean, you have to find a pocket where the need is so high that you are able to create a sustainable model out there. I think there is an opportunity to create a business model. You have to find that pockets where the user is desperate to find or use the service. I don't believe that a lot of behavior change happens because there is an incentive to change that behaviors. And as an entrepreneur, your opportunity is to kind of drive those behavior change and incentivize at the right point. So well, people would not change, right? People would remain in that sense. They would not, if they don't take care, they don't take care. The trend is there, but
Yeah, so how we can change? Because there are people, until unless they get a heart attack, they'll not move from their home to hospital. And
Well,
this
that's
can be preventive if, people take a right step for their health and, go for a regular health checkups and consult with the right doctor. As said, people are going to a chemist and buying the, Combi Flame without getting a right consultation with the right doctors. So how we can change this?
I would say I'm a very optimist on that piece. You identify the cohort which kind of is very important. There's a family history of MI. You find a way to kind of reach to that cohort, make that value proposition absolutely clear to that cohort, that what is the value proposition. Not doing a mass market will not work. You have to find a pocket where the user is desperate and your value proposition and communication is very, very sharp. I mean, I'm just brainstorming on that piece, but broadly speaking, I think you have to solve for that. There is no general point if anybody else wants to come on this.
I think I also come from a startup background. So I can tell you one thing is healthcare is the most difficult place to do a startup. Unless and until you have deep pockets, investment for about 5 to 6 years, it's going to be very difficult.
Thank you.
Any other? Yeah.
Hi, my name is Josefa. Spoke about AI can bring down cost in terms of healthcare. I would want to understand that with AI now we're going to be living with it and it's going to make deep inroads into healthcare as well. Would the cost of healthcare per se would come down?
My thought is, of course, the whole point of automation and putting AI ML in this to reduce down the cost. But again, we need to pick the right value chain where we want to implement it. And over the due course of time, it will come down. It's just the initial investment cost would be high, but then we'll look at how break even happens and in what time the return on investment come in. But over due course of time, it will come down.
And just to add to what Anurag said, one of the large use case for a healthcare establishment is to do the customer service, right? Reminding the OPDs, reminding the appointments, follow up, so on and so forth. And there was this study published in JAMA there where they used chat GPT driven messages versus human messages. And they found that the empathy component is very, very high because as a person, you are doing a repetitive job of interacting with so many patients. You can't fine tune your communication to that piece. And that ChatGPT was doing. So one of the cost reduction could be the customer support team, which you require an army of customer support team to support your establishment. That can go down. And similarly, there are multiple such inefficiencies built in the value chain where this can kind of reduce the cost. Yeah.
Yeah, I think doctor consultation costs will go up and not down with AI, and then they might go down in the long run. I think the reason for that is that the average length of consults in India is only 2 minutes. So as per a Lancet report, India's got the shortest doctor-patient consultation time, which means the doctor's not looking at your history at all. So, I mean, we can create a fantastic AI engine that summarizes your health records and presents it to the doctor. But doctor, will he look at it? You've got to force the doctor to look at it. So I think the only way you can force a doctor to look at it is if he's audited, which is not possible in a physical setting. So like in our digital clinic, and our doctor is forced to look at history. If he doesn't, he gets minus points. And end of the month, his salary depends on the quality he delivers, right? Because he's my employee. So in that setting, if I give him a AI summary, as opposed to having to read the summary which is there on the system, it might save him a few minutes of time. But in the average healthcare setting, where the doctor is anyway spending only 2-3 minutes with the patient, I don't think AI is going to reduce the cost. On the administrative side, you're absolutely right. There can be a lot of cost reduction on administration, reminders. For example, one of the biggest issues for any clinic, physical or digital, is no-show. And that's why doctors don't respect your time, because you never respect the doctor's time. And we have that problem as any other clinic, right? Where, like, we insist that all our appointments start on time. It's in our urban platform, it's a promise that we make. And the doctor gets penalized if the call starts more than 2 minutes, right? Is it 2 minutes late? So if the doctor is 2 minutes late in our system, it's a black mark. And that call gets flagged as a problem call. And it'll affect his overall rating for the month. But the problem is no-show. Doctor calls, patient says, I'm in a meeting. Boss, you have set up an appointment with the doctor. Patient says, I'm driving, call me after 10 minutes. You cannot, because 10 minutes, 15 minutes later, you have another patient, right? AI can help you there. Because AI can actually, for example, send you the reminders. We are already experimenting with robocalls, where you call the patient 3 minutes before, so you don't waste the doctor's time. So I think on the admin side, there could be cost saving. Consultation, I'm less
Even
sure.
AI can predict कि ये patient high probability of doing the no show based on some attributes, right? So,
Give an appointment in peak hours.
so thank you very much for a kind audience. I think we are running out of time. So thank you very much, panelists. I really enjoyed the conversation. I hope that was meaningful for the audience as well. Thank you very much.